There is a number, a specific clinically established number that represents the upper boundary of what urological medicine considers normal voiding frequency in a healthy adult over 60. Most adults do not know this number. Most adults over 60 who are exceeding it have never been told they are exceeding it because they have never thought to bring up their bathroom habits in a medical appointment. Partly because it is an uncomfortable topic, partly because frequency changes happen so gradually that the new pattern becomes the new normal before anyone has registered it as a change, and partly because the cultural script around aging has trained most people to expect and accept urinary changes as an inevitable and unaddressable consequence of getting older. The number is 8. 8 urinations per day, including up to 1 overnight, is the upper boundary of normal voiding frequency in adults over 60 by the clinical definition used by the International Continence Society and by the major urology guidelines published by the American Urological Association. Consistently voiding more than 8 times in a 24-hour period, or waking more than twice per night specifically to urinate, is a clinical finding that has a name, a diagnostic workup, and in the majority of cases, a treatable or meaningfully manageable cause. The name for daytime frequency above the threshold is urinary frequency. The name for waking more than twice per night is nocturia. Together, when both are present and exceed the established thresholds, they represent what the urology literature classifies as overactive bladder syndrome, a condition affecting an estimated 33 million Americans and whose prevalence in adults over 60 is approximately 40 to 44% in women and 27% in men. Nearly half of all women over 60 meet clinical criteria for overactive bladder. Most of them have never been told that what they are experiencing is a medical condition rather than an inevitable feature of aging. I am going to walk you through what is actually happening in the bladder and the nervous system when urinary frequency escalates beyond the normal threshold in adults over 60, because the mechanism is not what most people assume, and understanding it changes how you think about both the condition and the interventions available for it. I am going to tell you what the differential diagnosis looks like, because overactive bladder is a clinical description, not a singular diagnosis, and the conditions that can produce or mimic it range from benign and highly treatable to serious and requiring urgent evaluation. And I am going to give you a specific, research-grounded protocol for the behavioral, dietary, and pharmacological interventions that the evidence supports, because the management of urinary frequency in older adults has evolved significantly in the past decade, and most people dealing with this problem are receiving either no treatment at all or treatments that represent only the first and least effective layer of what is available. My name is Dr. Sandra Okafor. I have practiced urology with a subspecialty focus on female pelvic medicine and functional voiding disorders for 21 years. The reason I am making this video is the same reason I make every video in this series. The gap between what the research supports and what most people dealing with urinary frequency have actually been offered in a clinical setting is enormous. Most of my patients arrive having managed this problem privately, often for years, adapting their lives around it, mapping bathroom locations when they go to new places, avoiding long car trips, limiting fluids, wearing protective pads as a management tool rather than as a bridge to treatment, without ever having a structured clinical conversation about the full range of options that are available to them. That ends today. Before I go further, I want to hear from you. Drop where you are watching from in the comments. And if you are currently voiding more than 8 times a day or waking more than once per night to urinate, type yes right now. I want to know how many people watching this are in the clinical range I am about to describe, because the number in those comments tells me how much ground this topic has to cover. Let me start with what normal looks like, precisely because normal is the baseline against which frequency escalation is measured, and because most adults over 60 have never been given a specific normal against which to assess themselves. In a healthy adult with normal bladder function and normal fluid intake of approximately 1.5 to 2 liters per day, the bladder fills at a rate that should produce the urge to void every 3 to 4 hours during waking hours, producing 6 to 8 voidings per day total. A healthy bladder bladder at normal capacity holds approximately 300 to 500 milliliters of urine and should produce a comfortable first urge to void at approximately 150 to 200 milliliters, a sensation that is noticeable but not urgent, that can be deferred for a reasonable period without distress. The sensation should build gradually, from first urge to strong urge over a period of time that allows the person to reach a toilet without rushing or without the urge becoming overwhelming. And during sleep, a healthy adult over 60 should produce urine at a rate slow enough to allow a full sleep cycle. The normal circadian suppression of antidiuretic hormone that reduces nighttime urine production should limit overnight voiding to 0 or 1 episode. When the pattern deviates from this, when voidings exceed 8 per day, when the urge arrives with urgency that cannot comfortably be deferred, when nocturia disrupts sleep 2 or more times per night, when accidents occur because the urge arrives faster than the person can respond. These are not features of normal aging. They are features of a dysfunctional voiding pattern that has specific underlying causes and specific evidence-based treatments. Now I want to explain the underlying causes, because this is where the clinical picture becomes nuanced and where the importance of a proper diagnostic workup becomes clear. Overactive bladder syndrome is not a single disease. It is a symptom complex, urinary urgency, frequency, and often urgency incontinence that can be produced by multiple different underlying conditions, some of which overlap significantly, and some of which require very different treatments. Understanding the main categories helps you understand what your physician should be investigating and what questions to ask. The first and most common underlying mechanism in adults over 60 is detrusor overactivity, a condition in which the detrusor muscle, the smooth muscle that forms the wall of the bladder and that is responsible for the contraction that produces voiding, undergoes involuntary contractions during the bladder filling phase. In normal bladder function, the detrusor muscle remains relaxed as the bladder fills, contracting only when voiding is voluntarily initiated. In detrusor overactivity, the muscle contracts spontaneously, sometimes producing a sensation of urgent need to void even when the bladder contains only a small volume of urine, and sometimes producing actual involuntary urine loss. Detrusor overactivity has both neurogenic causes, arising from damage to the central or peripheral nervous system pathways that control bladder function, and non-neurogenic or idiopathic causes that are particularly common in older adults and that reflect the age-related changes in bladder muscle properties, in the density of bladder sensory nerve fibers, and in the central nervous system's modulation of voiding reflexes. The neurological connections to urinary frequency in older adults deserve specific mention because they are among the most clinically significant and least publicly discussed. The central nervous system exerts tonic inhibitory control over the voiding reflex through pathways in the prefrontal cortex, the anterior cingulate cortex, and the pontine micturition center. These central inhibitory pathways, in plain terms, the brain's ability to suppress the urge to void until socially and physically appropriate, are among the functions most vulnerable to the white matter changes and cortical thinning that accompany aging, cognitive decline, and early neurodegenerative disease. A study published in Neurourology and Urodynamics found that urinary urgency and frequency were significantly more prevalent in adults with mild cognitive impairment than in cognitively intact adults of the same age, and that the prevalence of overactive bladder in the MCI group was nearly twice that of the cognitively normal group. New onset or worsening urinary frequency in an older adult can be an early expression of neurological changes that are worth investigating independently of the urological symptoms themselves. This is not a connection that most general practitioners make in a standard appointment, but it is one that urology and geriatric medicine research has been documenting for years. The second major category of underlying causes is structural and anatomical, conditions that affect the physical architecture of the urinary tract in ways that alter voiding dynamics. In men over 60, the most common structural contributor to urinary frequency is benign prostatic hyperplasia, or BPH, the non-cancerous enlargement of the prostate gland that obstructs the urethral channel, impairs bladder emptying, and produces a compensatory increase in detrusor pressure that eventually generates irritative voiding symptoms including frequency and urgency alongside the obstructive symptoms of hesitancy and weak stream. Approximately 50% of men between 51 and 60 have histological evidence of BPH, rising to 90% of men over 85. In women, pelvic organ prolapse, the descent of the bladder, uterus, or rectum into or through the vaginal canal, can distort the urethrovesical junction in ways that impair bladder filling dynamics and produce urgency and frequency. The third category is metabolic and systemic, conditions outside the urinary tract that increase urine production or alter voiding patterns through systemic mechanisms. Uncontrolled diabetes mellitus produces osmotic diuresis. The kidneys filter excess glucose that carries water with it into the urine, producing dramatically elevated urine volumes that force voiding frequency. This is one reason that new-onset polyuria, the passage of abnormally large volumes of urine, should always prompt blood glucose testing. Diabetes insipidus, a different and rarer condition involving inadequate production or renal resistance to antidiuretic hormone, produces massive urine volumes through a different mechanism. Heart failure produces nocturia through fluid redistribution, fluid that accumulates in the legs and dependent tissues during the day due to venous insufficiency, is reabsorbed into the circulation when the person lies flat at night, increasing renal blood flow and urine production in the supine position. A study published in the Journal of the American College of Cardiology found that nocturia, specifically nocturia of 2 or more episodes per night, was an independent predictor of cardiovascular mortality in adults over 60 in a large prospective cohort, with the association strongest in adults whose nocturia was driven by nocturnal polyuria rather than by reduced bladder capacity. Waking twice or more per night to urinate is not only a urological symptom, it is a cardiovascular signal worth investigating specifically. The fourth category, and the one that is most actionable on the shortest timeline, is medication-induced frequency. A remarkable number of medications commonly prescribed to adults over 60 have urinary frequency, urgency, or diuresis as direct pharmacological effects or as side effects. Loop diuretics, including furosemide, sold as Lasix, and bumetanide produce rapid, intense diuresis that can force voiding patterns dramatically above normal thresholds, particularly when dosed in the morning or afternoon. Lithium produces nephrogenic diabetes insipidus in some patients. Certain antipsychotics and antidepressants cause urinary retention that fills the bladder to capacity before producing overflow urgency. Caffeine is a diuretic with a mechanism that both increases renal fluid filtration and irritates the bladder mucosa directly, producing urgency at lower bladder volumes than non-caffeinated fluids. Alcohol suppresses antidiuretic hormone acutely, increasing urine production in the hours following consumption. And the ACE inhibitor cough that I described in the blood pressure medication video, the cough produced by bradykinin accumulation, generates repeated Valsalva pressure that can worsen stress incontinence and bladder urgency in women with pelvic floor weakness. The specific question to raise with your physician in the context of urinary frequency is a complete medication review focused on urological side effects, asking specifically which of your current medications have diuretic effects or bladder irritant properties, and whether the timing or choice of those medications could be optimized to reduce their voiding frequency impact. That is a targeted clinical conversation that standard appointments rarely reach. Now, I want to give you the behavioral and dietary protocol that the research consistently identifies as first-line treatment for overactive bladder. Not because pharmacological options are not important or effective, but because the evidence consistently shows that behavioral interventions produce clinical improvements comparable to medication in motivated patients without the side effects that are particularly significant in older adults on already complex medication regimens, and because most patients dealing with urinary frequency have never been offered these interventions in structured form. The first behavioral intervention is bladder training, and it is the intervention with the most robust evidence base in the overactive bladder literature. Bladder training works by systematically and deliberately extending the interval between voiding events using cognitive and behavioral techniques to suppress the urgency signal before it reaches the urgency compliance threshold, the point where the person feels they must void immediately or risk an accident. The mechanism of bladder training exploits the neurological architecture of the voiding reflex. The urgency sensation produced by detrusor overactivity is not a fixed biological signal with a fixed compliance window. It is a sensation whose intensity is modulated by the central nervous system, by distraction, by breathing techniques, and by learned inhibitory responses that can be deliberately strengthened over weeks of practice. A Cochrane systematic review of bladder training in adults with overactive bladder found that structured bladder training produced clinically significant reductions in voiding frequency, urgency episodes, and urgency incontinence that were maintained at 6-month follow-up. The protocol I recommend to my patients is as follows. Begin by establishing your current average voiding interval, the time between your first morning void and your subsequent voidings, by keeping a voiding diary for 3 days. A voiding diary records the time of each void, the estimated volume, and whether it was accompanied by urgency or incontinence. Voiding diary apps, including Bladder Diary on the App Store and Urinary Tracker on Google Play, provide structured recording templates that make this straightforward. Once you have your current average interval, set a target interval that is 15 minutes longer. For the first week, try to hold for 15 minutes beyond the first urge before voiding. When urgency arises before your target interval, use the urgency suppression techniques I will describe. In week 2, extend the target by another 15 minutes. Continue this process until you reach a 3 to 4 hour voiding interval. The urgency suppression techniques that the research documents as most effective during bladder training include the following. At the first sensation of urgency, stop what you are doing and stand or sit completely still. Movement activates the pelvic floor and abdomen in ways that increase intra-abdominal pressure and worsen urgency. Stillness is the first countermeasure. Next, perform 5 to 7 rapid, strong pelvic floor contractions, what are commonly called Kegel exercises. The pelvic floor's reflex connection to the detrusor muscle means that pelvic floor contraction directly inhibits detrusor contraction through a spinal reflex arc. This is not an anecdotal observation. It is documented in urodynamic studies showing real-time suppression of uninhibited detrusor contractions following pelvic floor activation. After the rapid contractions, take slow, deep breaths and focus attention on something other than the bladder. The distraction component is a genuine neurological mechanism, not simply a psychological trick, as attentional resources directed toward a task compete directly with the brain's allocation of urgency signal intensity. When the urgency wave subsides, walk calmly to the bathroom. The second intervention is fluid optimization. And I want to be specific about this because the most common self-management strategy adopted by adults with urinary frequency is fluid restriction, which is counterproductive and which I need to address directly. Restricting fluid intake below 1.5 liters per day produces more concentrated urine, which irritates the bladder mucosa directly and actually worsens urgency without reducing voiding frequency. It also contributes to constipation, which, through the shared neural innervation of the pelvic floor and the direct mechanical pressure of loaded sigmoid colon against the bladder, significantly worsens bladder urgency. The optimal approach to fluids in overactive bladder management is not restriction, but redistribution, maintaining a total daily fluid intake of 1.5 to 2 liters, consumed at an even rate throughout the day rather than in large boluses, and eliminating or significantly reducing the specific fluids that have the highest bladder irritant properties. The bladder irritants with the strongest research support are caffeine, which is the most potent bladder-specific irritant in common dietary use, and whose complete elimination in overactive bladder patients produces symptom reductions equivalent to a starting dose of pharmacological treatment in some studies. Carbonated beverages of any kind, including sparkling water, citrus juices, tomato-based products, artificial sweeteners, including aspartame and sucralose, and alcohol. A clinical trial published in the British Journal of Urology International found that caffeine reduction to below 100 milligrams per day, which represents a reduction from the average adult intake but not complete elimination, produced significant reductions in urgency episodes and daytime frequency in adults with overactive bladder. For those for whom complete caffeine elimination is not achievable immediately, a structured stepwise reduction, replacing one caffeinated beverage per day with a non-caffeinated alternative each week, is both more sustainable and more effective than abrupt elimination, which produces caffeine withdrawal headaches that most people abandon the intervention to escape. The third intervention is pelvic floor rehabilitation, and I want to distinguish this from the generic instruction to do Kegel exercises that most women with pelvic floor dysfunction receive and that most find insufficient because the instruction lacks the precision and progressive loading that produces meaningful, functional outcomes. Pelvic floor rehabilitation, as practiced in specialized pelvic physical therapy, involves a comprehensive assessment of pelvic floor muscle function, identifying not only weakness but hypertonicity, which is paradoxically common in women with urgency symptoms, and which makes standard Kegel exercises counterproductive because they further tighten a floor that is already too tight. A 2022 systematic review published in Urology and Urodynamics found that pelvic floor muscle training, when properly supervised and individualized, reduced urgency incontinence episodes by 65 to 70% in women with overactive bladder, an effect size comparable to the most effective pharmacological agents and without the systemic side effects, particularly the anticholinergic burden of bladder medications that I described in the medication video. The specific recommendation is to request a referral to a pelvic floor physical therapist rather than attempting to self-direct pelvic floor exercise based on generic Kegel instructions. Pelvic physical therapy is a subspecialty with trained practitioners who assess the specific functional deficit, whether weakness or hypertonicity or coordination, and design a progressive program accordingly. The American Physical Therapy Association's directory at pelvicrehab.com allows you to search for certified pelvic health physical therapists by location. The fourth intervention is timed voiding, a structured approach to voiding that eliminates reactive voiding in response to urgency and replaces it with a proactive schedule that empties the bladder on a timed interval before urgency-driven contractions can build to the urgency threshold. Timed voiding is particularly valuable in adults with cognitive changes, neurogenic bladder contributions, or mobility limitations that reduce the time available to respond to urgency before an accident occurs. The evidence base for timed voiding in this population is strong. A randomized controlled trial published in the Journal of the American Geriatric Society found that prompted timed voiding reduced urinary incontinence episodes by 43% in nursing home residents over a 6-month period, and subsequent research has confirmed the approach in community-dwelling older adults. The specific protocol is to set a timer to void every 2 to 3 hours, regardless of urge level, particularly in the morning and early afternoon when voiding frequency tends to be highest. I want to tell you about a patient I will call Eleanor. Eleanor was 69 when she came to my clinic referred by her primary care physician, who had finally initiated the referral after Eleanor had mentioned at 3 consecutive annual physicals that she was waking 3 to 4 times per night to urinate and was voiding 11 to 13 times per day. Eleanor had lived with this pattern for 6 years. She wore a pad every day. She had stopped attending evening events because she did not trust herself to manage the urgency away from familiar bathrooms. She had reduced her fluid intake to less than a liter per day because she believed this was helping. She drank 3 cups of coffee per morning and had never connected the coffee to the urgency. She had been told twice by different physicians that bladder changes were normal with age and that she could try cutting back on fluids. That was the extent of the clinical response she had received in 6 years. When I completed a comprehensive voiding assessment, including a voiding diary analysis, a post-void residual ultrasound to rule out incomplete emptying, a urinalysis and urine culture to rule out infection, and a pelvic examination, Eleanor had idiopathic detrusor overactivity with no structural abnormality, no significant post-void residual, and no infection. Her bladder was neurologically hyperresponsive, and she had been managing its hyperresponsiveness by staying close to bathrooms and restricting fluids, both of which were reinforcing the problem rather than addressing it. She had never been offered bladder training. She had never been given information about caffeine as a bladder irritant. She had never been referred to a pelvic floor physical therapist. We implemented the protocol I described in sequence. Week 1, voiding diary and identification of baseline. Week 2, elimination of caffeine, all 3 morning cups replaced with decaffeinated alternatives using Pete's Major Dickinson's Blend Decaf, available at Costco and major grocery chains for approximately $12 to $16 per 12-ounce bag, which Eleanor selected because it was the closest to her regular coffee in flavor profile. Week 3, fluid redistribution to 1.5 liters spread evenly through the day, active discontinuation of fluid restriction. Week 4, bladder training beginning at her baseline interval and extending by 15 minutes per week. Concurrent referral to a pelvic floor physical therapist who identified mild detrusor sphincter dyssynergia, a coordination problem between bladder contraction and sphincter relaxation, and began individualized pelvic floor rehabilitation. At Eleanor's 12-week follow-up, her voiding diary showed 7 to 8 voidings per day, within normal range. Her nocturia had reduced from 3 to 4 overnight voids to 1, occasionally 0. She was no longer wearing a pad daily. She had attended her granddaughter's school play 2 weeks earlier, an evening event at an unfamiliar venue, without incident. She told me that she had not done something like that in 4 years. Not because her bladder had been surgically corrected, because 6 weeks of caffeine elimination and behavioral training had addressed the 2 most modifiable drivers of her hyperresponsive voiding pattern, and because pelvic floor therapy had addressed the coordination deficit that had made urgency more difficult to suppress. Eleanor asked me the question I am asked most often after results like hers. She asked why 3 physicians over 6 years had told her this was a normal feature of aging, rather than initiating what turned out to be a straightforward and highly effective conservative treatment program. The honest answer involves the structure of primary care appointments, the low priority historically assigned to quality of life conditions that are not life-threatening, and the persistent cultural belief among both patients and some clinicians that urinary changes after 60 are simply the expected cost of growing older. None of those explanations make them acceptable, and the evidence that conservative behavioral treatment is as effective as pharmacological treatment for overactive bladder, without the side effect profile that makes bladder medications particularly problematic in older adults, has been available in the urology literature for more than 15 years. The medications for overactive bladder, the muscarinic antagonists including oxybutynin, sold as Ditropan, tolterodine, sold as Detrol, and sulfonacin, sold as Vesicare, and the newer beta-3 agonist mirabegron, sold as Mirbatric, are real options with real evidence when behavioral treatments are insufficient. But as I noted in the medication video, the muscarinic antagonist carries significant anticholinergic burden that the research links to cognitive impairment risk in older adults, and they should be used at the lowest effective dose and reassessed regularly for ongoing appropriateness. Mirabegron, which works through a different mechanism without anticholinergic activity, is generally preferred in adults over 65 by the American Geriatric Society's Beers criteria guidance for exactly this reason. It provides effective bladder relaxation without the cognitive risk profile of the older anticholinergic agents. If your physician is managing your overactive bladder with oxybutynin and has not discussed the anticholinergic burden concern or mentioned mirabegron as an alternative, that conversation is worth initiating. I want to close with the reframing that matters most. Urinary frequency above 8 times per day is not a feature of aging. It is a clinical finding with a workup, a diagnosis, and a treatment pathway. Waking more than once per night to urinate deserves a medical evaluation that considers not just the bladder, but the cardiovascular system, the metabolic system, the neurological system, and the medication list. Adapting your life around bathroom proximity, the mapping, the pad, the avoided events, the restricted fluids, is a coping strategy, not a treatment. And the behavioral tools I have described today, bladder training, caffeine elimination, fluid redistribution, pelvic floor physical therapy, have the evidence base of clinical trials behind them and the track record in motivated patients who receive proper guidance of producing outcomes that most people dealing with this problem have never been told are available to them. Count your voidings tomorrow. Keep a voiding diary for 3 days. If your pattern exceeds 8 times per day or 2 overnight voids, bring that data, specifically with the numbers, to your physician. Not a general complaint about going to the bathroom a lot. Specific data. That data initiates a different clinical conversation than a general description. And that conversation, when it is guided by the information in this video, has the potential to return to you the evening events you have stopped attending, the car trips you have been avoiding, the nights of sleep you have not had in years, and the quiet confidence that comes from knowing where your own body begins and ends rather than where the nearest bathroom is. I want to ask you one question before you close this. Without thinking about it too hard, roughly how many times did you urinate yesterday? Type the number in the comments. No judgment, just data. And if the number is above 8, and if today is the first time anyone has told you that 8 is the clinical threshold, I want to know that too. Because that gap between the number you have been living with and the number someone should have explained to you years ago is the gap this video was made to close.